free to chuck a question in, either in the chat or out loud if you're that kind of person, if you have any on the way. Otherwise, we should be good. So broadly, stuff that we're going to talk about today, we have broad approachy type stuff, monoarthropathy, polyarthropathy, miscellaneous, and then weird stuff. The weird stuff is pretty minimally important, I think. So it's in here for completeness. If we don't get to it, it's in the slides. You guys can have a look at it later. But the important stuff is certainly your monoarthritis, especially acute ones, and polyarthritis. So I don't know what your guys' matrix looks like. This is what mine looked like. So the important things in here, definitely OA, definitely gout, definitely your infections, RA. And I'll probably put GCA PMR as kind of an R1.5. The rest is not that important, including this, although it's in here again as well. Just as a note on what these are about, fever is obviously for your infectious ones. Limb and joint pain swelling is arthritis. And the red eye, if you see someone who's got joint problems, it's got any kind of reference to a red eye, dry eyes, itchy eyes, whatever, think some kind of immune type thing. So it's the kind of thing you might find as an extra articular manifestation of something like rheumatoid, or if you think back to something like IBD, which is another autoimmune inflammatory condition, you can also get uveitis or episcleritis from that as well. So broadly, we've got monoarthritis, and the important ones I've bolded here, polyarthritis and the weird stuff. If you've been anywhere near central, you'll have heard 5 causes of symmetrical deformity hand polyarthropathy. And it is actually pretty worthwhile having these in the back of your mind as things that you can trot out. They're also quite distinct if you can keep them all in mind, which helps to kind of differentiate things when you get to questions. So we'll be starting with general stuff. So I guess the easiest way to think about what you need to do is to try and not miss anything important, essentially. So you don't have to include, everything under the sun, but you want to make sure that you get everything that's common in there, and that if you want them to stay alive for the next days, you don't miss a couple of days, you don't miss anything extremely important. So for example, if someone's got an acutely swollen, red, hot knee, lots of people get gout, but you have to make sure they don't have septic arthritis or osteomyelitis just in case. As I've said here, things like reactive arthritis or pseudo gout, you're more likely to have as kind of something you mention off the cuff in a station or as an option in an EMQ. It could be the answer, but you're not going to have, like an 8-minute station about pseudo gout. So as far as history taking goes, lots of things apply to many conditions. For example, with pain, always where, when, quality, quantity, leave you angry, all your classic stuff. And then you can ask specific things for arthropathies. So other than pain, stiffness, and that can include things like duration, location, if it comes back when they stop, which is called the gelling phenomenon. Loss of function, range of motion, which is quite important, especially with your more widespread conditions like osteoarthritis, rheumatoid arthritis, and so on. Because obviously one of the big problems with these conditions, which are quite common, is that people can't do what they normally can. And generally there are going to be marks for finding out they can't do these things and being nice to them about it and about how difficult it is and so on. And then after you've kind of established what kind of joint problem you think they have, you can try and ask them specific things to rule things in and to rule things out. So the big important set is rheumatoid and your osteo, because those are common, they affect lots of joints, and everyone gets very confused because they both affect the hands, they both make them hurt, they both make them stiff, and so on. It is worth separating them though. So if you get different people, you'll suspect different conditions, you'll get different histories for them, different exam findings. So for example, you can get a picture of hands. So there's some in this PowerPoint, which we'll go through, different x-rays and a very, very different management. So at its most basic level, essentially osteoarthritis is a mechanical problem. So you've got 2 bones rubbing against each other because you've lost the cartilage that should be lining the space in between, and that's what's causing the pain. Whereas in rheumatoid, you're damaging the bone and you have all this inflammatory infiltrate into the area. So the problem is not that the cartilage has been worn away over time and the bones are running into each other. It's that you actually have cells actively arriving here and attacking what's here, which is why you can damage all these areas that aren't just in the articular space here. So areas that are affected for osteo. So if you're a visual person, just look at this and you see that it's all the distal stuff. You don't have to worry too much about the MCPs for this one. And take note of the fact that that first carpometacarpal joint is very, very commonly affected. It's actually the most commonly in the entire body. Otherwise, you get this a lot more in the big joints as well, like your hips, your knees. And the big separating thing, which I think everyone always forgets, is that osteo is the one that does affect your DIPs. If you can't really remember which one does which, as long as you can remember that Bouchard's and Heberden's nodes are associated with osteo, you know that those are proximal and distal, or at least that those are the two interphalangeal joints, which means that this can't be the one that's sparing one of them. Rheumatoid, we get more problems in the metacarpophalangeal joints, so along here, more in the carpal bones themselves, and we particularly spare the DIPs and the thoracolumbar spine in here. Rheumatoid is also a condition that has a lot of extra articular manifestations, whether that be people who just turn up and are like tired, fatigued, they have malaise or things like that. But it can also affect internal joints with things like pulmonary fibrosis is probably one of the most classic ones. Theoretically, you can get rheumatoid nodules anywhere. Most people aren't going to have them, in places like the heart, giving them heart block and things like that, but it's possible. So the risk factors, similar initially, so both have more common in females with family history and older age. But then if you think back to what we've just said, each condition actually is, osteo is going to be much more a mechanical problem. So you're going to have problems like obesity putting extra pressure on them, joint injury, which means that you've already kind of damaged the linings, for example, the cartilage, the meniscus, whatever, and repetitive stress. Whereas with rheumatoid, the mechanical factors aren't as important. So things like smoking and other autoimmune disease will actually make you think of that more so. So the history to compare the two. So the morning stiffness for osteo tends to be short-lived, whereas RA, it goes for a really long time. So it's got a prolonged morning stiffness. Having joint pain and functional impairment is going to be fairly similar between the two. But osteo is worse with activity because we have that problem, the bones grinding up with each other. Whereas rheumatoid will give you a gelling phenomenon where people feel better when they do more activity, as they describe it, their joints loosening up or something like that. And then if they stop, take a rest, sit down for an hour, then they find that stiffness kind of goes back to where it was to begin with. The systemic features also aren't really present in OA, but can be in RA. And the medications are quite different for the two. So osteoarthritis, you can fix with simple analgesia, things like NSAIDs or Panadol. That's not really that helpful for people who have rheumatoid. Then exam. So this is a list of a whole bunch of signs. I think it's important probably just to be able to associate these with each condition, because most of your exam in rheumatology, at least in the hands, a lot of it is inspection. A lot of it is just looking for things that aren't there and listing them off so people know you're looking for them, as well as naming whichever things are there. So muscle wasting is not too specific, but Bouchard's nodes are on our proximal interphalangeal joints, Heberden on the distal ones. The first carpometacarpal you might see as a square thumb. Crepitus shouldn't be here, it probably should be on the feel, and reduced range of movements by asking them to do things, obviously. From the field, we've got the osteophytes, there's the crepitus, and they aren't boggy and inflamed, which we'll get to, which is a sign of rheumatoid instead. You should test their range of movement and then any functional test you like. So everyone's got the ones they do. You might do handwriting, you might be doing up a button, opening a bottle, pretending to turn a key, whatever you like. So this is an example of a set of osteoarthritis hands. So the main things to take away from this is probably that you've got these distal interphalangeal Heberden's nodes here, or the proximal Bouchard's ones here. On the rest of the hands, there's probably not too much to comment on. There might be a little bit of squaring of the thumb here, but it's not too obvious. Just as a general thing as well with looking at hands, this will come into play more with rheumatoid and even maybe gout. I think it's useful to have a way you go about it. So for me, I like to do it going from proximal. So in this case, you can come down to the wrist and you say there's no deviation at the wrists. Then you get to the thumbs and you might comment on that little bit of squaring there. Then you get to your carpometacarpals and you say, oh, it's not really, your metacarpophalangeal joints along here. And you say there's not too much swelling there, which is consistent with osteoarthritis. Then you get to your proximal joints and you'll find these Bouchard's nodes and then the Heberden's nodes, the distal. So for rheumatoid, we have a whole lot more going on. So if they sound like they've got tons of things going on and it's not just the name of nodes, you got a pretty good odds that it's probably going to be RA of the two. So you can get radial deviation at the wrist, and that's, if you think of it with your own hands out in front of you, that's going to be at the wrist coming towards the center, and then ulnar deviations are going away from the center at their metacarpophalangeal joints. The DIPs might look like they're affected, but the actual joints themselves won't be inflamed or ruined on their x-rays. They might look like they're abnormal, but that's mainly because they've got other changes that are doing that. The other deformities here, so we've got swan neck deformity and Boutonniere's deformity. We've got bowstring extensors, Z thumb, and swelling around those joints. And that swelling, when you feel it, will always be described as boggy. So it's red, it's warm, it can be quite tender. And they can have a painful squeeze test, which is basically when you essentially squeeze at the carpometacarpal joints with your hands. And so that'll look kind of like this. And if you're squeezing there, you'll find that that's actually quite a sensitive test for rheumatoid arthritis. And then the rest of it is the same as for osteo. You're still going to check all of these things. Okay, so this is one set of rheumatoid hands. So we can go through that whole kind of process here. So if we start at the wrist, you can see that this one is probably a bit deviated. Difficult to tell because we can't see where her arms are. So we'll skip that for this one. The thumbs, we've probably got some Z thumb there. It's not a perfect Z, but it's about as close as you're really going to get with most people. Next, we make it to our metacarpophalangeal joints, and you can see that they're quite swollen and inflamed. They look abnormal. And you can see how this next bone here looks kind of displaced. It looks as if it's been shifted down, kind of like, like that. And so that's something you can comment on. Then we get to our proximal joints. We can't really see too much swelling here, but what we can definitely see is that there's some deformity here. So the two that kind of appear from a straight finger are the swan neck and the Boutonniere deformities. So swan neck, I literally just have to do this to myself to remember. So it'll look kind of like a swan, which is why they go for it. So you get excessive flexion at the distal interphalangeal joint and excessive extension at the proximal one. And you'll get the opposite for Boutonniere. So they'll have excessive extension distally and flexion proximally. This also will be a problem that they can't correct. So if you push their hands together, those fingers won't go back into place, which separates it from a different condition, which we'll get to later, called Jacquard's arthropathy. Okay. So this is another set of hands. We don't need to labor the point on what's on them, but as you can see, there's probably some deviation at the wrists here. There's certainly on the deviation at the MCPs. The thumb we can't really see properly, but I suspect it's going to have some Z thumb. Carpometacarpals, again, quite affected. Difficult to tell exactly which deformities they have on the finger, but this probably is a Boutonniere. So excessively, a fixed flexion deformity here proximally and a fixed extension peripherally. Well, yeah. Okay, so actually looking for them. So the most useful set of tests for these is actually not going to be a whole bunch of blood tests and x-rays if you're thinking about OA. OA is quite problematic to investigate in the sense that even if you find nothing, you can still diagnose someone with OA. So the bloods will be totally normal. In fact, if they're not normal, you probably want to think, is there something else going on? And the x-ray, so some people can have symptoms and no x-ray changes, and some people can have no symptoms and x-ray changes. So yes, you're going to end up imaging them, but they aren't kind of the catch-all. They don't definitively say yes or no. For rheumatoid, you can get quite a lot more going on because it's, a more intensive disease. It's an autoimmune problem. So you might get an anemia of chronic disease on your FBE. UECs and LFTs are important because you're going to start on some stronger medications. The ESR and CRP will be elevated, which is different from osteo. And they'll have elevated rheumatoid factor or anti-CCP antibodies. And of these two tests, the anti-CCP is a more specific test. So if you have to pick one, you're going to go with anti-CCP, and you still with X-ray, of course. So this is just a set of normal hands. So things to take away from this is basically just what kind of your normal joint spaces look like. So they're not, these massive wide ones like you can see in the knee sometimes, but there is quite a clear separation between our bones here. Coming more proximally as well, you can see the carpometacarpals are quite nice. sorry, the metacarpophalangeals. The carpometacarpal, a little bit gross, but largely pretty okay. And so then if we compare that to here, so this is osteo. So there is a mnemonic for this, which is included in the notes on this PowerPoint that you guys can look at later if you want, or now if you've got it already. So for osteoarthritis, it's loss. So the L is for loss of joint space. So you can see here that joint space isn't as nice and symmetrical as we had before. You can see that over here as well. The O is for osteophytes. So that's little growths of bone into the spaces. So you might see something like this, or the little bits coming off here and here, or even out here. The S is for subchondral sclerosis, which is essentially thickening of the bone just deep to where the cartilage would normally be. So the cartilage is basically where the joint space would be. So you can see that either side of this, you've kind of got this excess whitening compared to before. So here, they're quite dark at the ends of these bones, but here you can see this whitening happening. And the last S is for subchondral cysts, which very rarely going to be able to see. Feel free to mention it as you can't see any, but that kind of completes that. Whereas these hands are rheumatoid hands. So rheumatoid, I still think if you think from proximal to distal, you won't miss anything because rheumatoid can affect these carpal bones quite badly. So you can see that it's quite difficult for us to distinguish these bones from each other. They all look quite fused and gross. Coming up to carpometacarpal, they might be okay on this side, maybe a little bit abnormal here. And then we get to our metacarpophalangeal joints, and these look pretty bad. So this side's all right. Then we've got some erosions happening here. We've got plenty of erosion here and here. And so there is a mnemonic for these hands as well, which is lose. So the L is for still loss of joint space, which you can see, say, here in the proximal interphalangeal joints. Then we have osteopenia. So that's kind of, you can think of it as the bone looking paler, essentially, because we're losing bone density near the joints. So things like this or this. Separate to erosions, because erosions will be happening from the periphery. Soft tissue swelling. So you can see that the kind of soft tissue around the joints looks to be a bit lighter than you would normally see on a hand x-ray. And then the E is the erosions, which we've mentioned already. You can also see that largely the distal joints look to be relatively spared. So there's not really, if you compare the joint spaces between them, they're quite significantly better proximally, distally. Okay, so just a moment on management. I'm sure you've all heard something like this before, but it is definitely worth repeating and making sure you kind of go through all of them. So you should always be thinking conservative first, medical if you must, and surgical if you absolutely have to. Especially for your more chronic arthropathies. For an acute, you might go quite quickly to surgical, but generally you want to try and at least tick something off in each of these. Okay, so for OA, because it's a mechanical problem, we don't have DMARDs or disease-modifying anti-rheumatic drugs. If you remember what anti-rheumatic means, then you won't say this for osteo, you'll say it for rheumatoid. Lifestyle changes, so weight loss and exercise can help. Non-weight bearing if they're having quite a lot of pain, but ideally you want them to pretty much do what they're comfortable with. And then other non-pharmacological things you can help them with. So CBT, despite being quite a joke for a lot of people, is always a good thing to throw out because it seems to work for everything. And you can also give them some help with exercise if they're having problems with that too. Then continuing onwards, so now we're into the fun bits of medications. So generally you want to try and keep them on simple analgesia. People have tried things like opioids, but generally the risks aren't really worth the benefit. I find that simple agents tend to work quite well. Of them, NSAIDs can be problematic in a few areas. So you can get peptic ulcer disease or other GI bleeding. It can increase your cardiovascular risk. You can have renal injury, especially in the patient who, say, has hypertension and is on an NSAID and ACE inhibitor and a diuretic. You can still use them, but it's safer usually to just say Panadol instead because we don't really have any bad long-term side effects from that we know of unless someone takes a massive dose in one go. Steroid injections can also help, but they aren't really a long-term answer. They might be useful kind of for someone who's gotten worse now and you want to get them through rehab or something like that. And then last line is surgical. So you can do cleanups, but the best thing is really a joint replacement. That is quite a big operation though. So if you were to be talking to someone about this, you'd be talking about, the risks of a surgery and the potential for them to manage it medically and with fairly conventional means otherwise. Rheumatoid, on the other hand, it's not a mechanical problem, it's an inflammatory problem. And so we can still do lifestyle and drug things, but the main thing is going to be getting them on a long-term DMARD. So lifestyle, we've got over here, so exercise, and then any other risk factors they have, you can try and drop, because rheumatoid arthritis itself is also a risk factor for cardiovascular disease because it's a chronic inflammatory state. These drugs are here, but they're not really used, especially long-term. You don't want to keep people on a long-term steroid or a long-term NSAID if you don't have to. So ideally, you want to end up on methotrexate. Methotrexate is the Rolls Royce, as some people say, of anti-rheumatic drugs. If you don't know, you should just say it with folic acid, because people can get deficiencies otherwise. There are a few others that you should probably have heard of, like hydroxychloroquine, I suppose especially this year, leflunomide, sulfasalazine, and then biologic agents, which you might be more familiar with from, say, IBD again, which work to suppress cytokines. But this is probably beyond what you really need. The main thing is definitely going to be the methotrexate. So Prof. Leach loves methotrexate. She calls it vitamin M, and if possible, would put it in the water. I don't know about putting it in the water, but it's definitely a very, very good drug. People who I've talked to who are on it have, said it's life-changing. So if you can't remember what to do, if you've thrown out the structure, just say methotrexate and then take a second to think about the rest, because it really is the core of managing rheumatoid. Okay, the other ones aren't that big a deal. So Jacquard's arthropathy is actually secondary to lupus. And the problem in that is not that you're actually kind of eating up the bones with inflammation or a mechanical problem. It's that the ligaments that are actually on your fingers are starting to get loose or lax. And so when that happens, they don't resist movement the way that they're supposed to. And so you can get a lot of things that look like rheumatoid arthritis. So you can get your boutonnieres and things like that. The thing that will separate them, as I mentioned before, is that if you get them to put their hands together like this, the deformities will correct, because you're essentially pushing everything back into the right place, because nothing is stopping them. It's that nothing is keeping them there. For psoriatic arthritis, you can get that before or after someone gets skin psoriasis, and it's a seronegative spondyloarthropathy, which basically just means it doesn't really have the antibodies that we would expect in something like rheumatoid. And chronic tophaceous gout is something that results from uncontrolled and long-standing gout. That's pretty nasty. So you can get quite a lot of tophi around, hence the name, tophaceous. They can be quite ulcerated, quite painful, and they can keep having acute attacks as well, even while they have this. So for the others, things that you can think about. So FB, ESR, CRP, and X-ray is probably reasonable for most arthropathy. Things that you might add on. So chronic gout, you can add on UECs, because uric acid is bad for your kidneys, urate or uric acid itself, and definitely a joint fluid. So you can figure out exactly what's going on. You can rule out an infectious cause. Psoriatic is essentially the same as on this side, and you can also figure it out in history and exam. And Jacquard's, you basically need to figure out, do they have lupus? So you can do all your lupus tests, anti-double-stranded DNA, anti-Smith, they'll have low complement, and maybe anti-phospholipid serology. So Jacquard's, we've kind of talked a little bit about this already. So correctable, otherwise looks like RA, can have some features of lupus as well, like malar rash, uveitis, which is that red, dry eye I was talking about, and serositis, which can cause pain, essentially in anywhere that's covered by pleura/viscera/pericardium. So you can get pericarditis-like pain, pleuritic pain, and peritonitic pain. So the hand X-ray, if you have a look, is actually not bad in terms of the bony structure. Obviously, this is quite deviated from where we'd normally see our hands, but the actual bones themselves look quite good. You still have maintained joint space. You don't have any erosions, don't have any osteophytes. Everything actually looks quite good. It's just that everything is out of place, and that's the main problem here. And basically, all you can do is really treat their lupus. Chronic tophaceous gout, so you get pearly, which is the big word for it, and you can get them pretty much anywhere. But common places would be things like over your Achilles, or even on the olecranon as well. They these hooked, punched out lesions here. So you can see how we have this nice border around our erosion here, or here, or here. This is obviously quite a severe form of gout, and so it's associated with renal impairment and diuretics. And long-term, these people all need to be on urate lowering therapy. So something like allopurinol, probenecid, or a combination. And then you essentially have to maintain them like you would with someone who's just had acute gout. So for psoriatic arthritis, there's some extra signs. So we've got family history and a rash. These are these salmon-colored silvery scaly plaques. So they might have that rash, dactylitis, which is swelling of the fingers. You can see this finger looks a bit fat here. Nail pitting and oil drop signs, which are in the nails. This can range from oligoarthropathy, so where they just have like a few here and there that are affected, to arthritis mutilans, which is where the hands are quite intensely affected and everything looks very, very out of place. The key X-ray finding for this is this pencil and cup sign, which requires a significant degree of the eye of faith. But if you can imagine that this little bit here is kind of like a pencil, and then you have the cup here that it's going into. Bit of a terrible name for a sign, in my opinion, but it's there, I guess. Really, though, a lot of this is going to come from your history. Management, it's kind of like managing psoriasis. I'm not going to go too much into it because you don't need to know tons about it, but still lifestyle, medical, not really surgical because it's an inflammatory problem and an immune problem, obviously. Monoarthropathy, so gout. So what is it? It's essentially joint damage and pain because you've deposited a whole bunch of uric acid in and around your joints. So it's one of the crystal arthropathies. You only need to know of two. And the way that you get is that people eat purines, which eventually get turned into uric acid, which should then get kicked out by the kidneys. So problems arise if either too much comes in or if you don't get rid of enough. So it's practically illegal for someone to have gout if they aren't male in a question. They're always going to be a middle-aged to old dude who maybe has arthritis, who's turned up with an acutely painful toe. They might have too much shellfish or beer or red meat because all of these things contain quite a lot of purines. And they can be associated with things like metabolic syndrome and CKD because that'll make it problematic for you to get rid of your excess urate. Drugs impairing renal function will do the same thing. So if you see over here in the pathway, the most important thing here is that the xanthine is here because xanthine oxidase is probably the main target for long-term treatment, because if we can block it off there, then we can just keep things as xanthine and not create too much urate, because the problem with urate is that that is what is going to deposit in your joints. Okay. So yeah, middle-aged or older man presents with sudden onset of agonizing pain in his big toe with some swelling, redness, and tenderness. You might have recently had quite a bunch of alcohol, or just a big meal, or have started on some diuretics. In particular, thiazide diuretics are quite bad for increasing people's uric acid levels. So then they can get tophi. They might not want to walk or let you touch them. On exam, you should definitely check their vitals because you want to make sure they don't seem to definitely have septic arthritis. So that's looking for your fever, hypotension, tachycardia, tachypnea. But having said that, regardless of what you find there, you are going to end up doing investigations anyway. They'll have a red swollen joint, usually only one, and they might have some tophi if they've got chronic disease. So investigations, the biggest one here is the joint aspirate. You basically have to do that if someone has an acutely swollen red joint. And the things that you want to ask for are the culture, cells, crystals, and stain. So culture and stain kind of rules out your septic arthritis. And then the crystals is looking for these negatively birefringent needle-shaped crystals. So basically they look kind of like this. On your bloods, so if you think back to what we said before, so FBE, UEC, ESR-CRP, urate monitoring is not useful in the acute episode because when you have gout, that makes your body get rid of more uric acid. So that means that at the time, their uric acid might not look as bad as it really is. So you can do it, but you would want to mention that you're going to be monitoring that over time. And then you can image it and you'll look for the same things that we've already talked about, those hooked out erosions. Management. So acutely, you need to fix the pain. So NSAIDs is number one, unless they have a reason why they can't. Otherwise, other options, colchicine and steroids. You need to tell them what it is, what causes it, what they're at risk of, and what that's alluding to is basically chronic disease, long-term need for urate lowering therapy. Long-term, we still go through lifestyle first, so losing weight and kind of getting away from that metabolic syndrome, reducing dietary purines, so essentially cutting down on things that we mentioned before, things like, especially beer is usually an easy one, or easy in the sense that it's probably going to be there. Exercise and diet because they've got hypertension. And then urate lowering drugs, these should be used in the long term to try and keep their uric acid from getting too high so that they don't have repeated episodes. Because once you've had one, you're at a high risk of having more. When you put someone on a urate lowering drug, you also need to give them flare prophylaxis because starting it is associated with a high risk of setting off a flare. So you can just use colchicine for that. If there's a reason why I can't think of one, but if there's a reason why they couldn't use colchicine, then you could always give them a steroid or an NSAID. Bowstring extensors, okay. So someone just asked what bowstring extensors are. I haven't got a picture of it right now, but I'm sure I can find one. So essentially what that is if you take your own hand and you have a look at the back of it, and you can see all these extensor muscles, maybe not as obviously as on mine, but you can see all these extensor muscles here in the sense that they will extend your fingers. Bowstring extensors is when they're quite elevated away from the hands. Trying to think about how far I can get mine up. Something closer to like that, you would be thinking about as like a bowstring extensor. So where it's quite elevated away from the surface of the hand. Hopefully that helps. If you find a picture of it as well, it'll look basically like that. So allopurinol, you don't need to know tons about dosing and lots of things, but it's good to know a couple of things about it. The big thing here is that you shouldn't stuff around with the urate lowering therapy during a flare. So you should start low and go slow once they're out of it. And then you have to treat to target. And what that means is that you want to make sure you don't just give them 100 milligrams of allopurinol and send them on their way and never see them again. Because if you give, everyone responds to it differently. And if you don't actually get their uric acid level down, then they're essentially taking this pill, every day forever with no benefit from it. Having said that, you can't start it, but you shouldn't stop it during an acute attack either. So essentially whatever level it's at is whatever level you should keep it at. This is the stuff you want to prevent. So this is that kind of pearly appearance. It's quite shiny and raised compared to say that kind of dull looking hand we can see in something like osteoarthritis. Oh yeah, the other crystal arthropathy is pseudogout. So this, instead of giving us uric acid, gives us calcium pyrophosphate instead. So old ladies get it, so I guess that's one point of difference, because that's as opposed to usually being a middle-aged man. And they often get it in the knee instead of the first metatarsophalangeal joint. The keys on the investigations are you can get chondrocalcinosis, which is this white line you can see between the femur and the tibia on an X-ray, and that you can get different crystals. So they're going to be positively birefringent and rhomboid instead. And management, you can't really give them a long-term, calcium pyrophosphate lowering agent. You basically just treat the acute episode with something like local steroids, not long-term oral ones, NSAIDs or colchicine, and that should get rid of it. So the crystals, so rhomboid basically just means more squared. And the joint lines here, so you can see that in this nice space here where we would normally have, quite a clear appearance, we can see this crap in here. As far as needing to know the treatment of the target, you don't really need to know the numbers. You don't need to know the numbers for most things. So you're not going to have to sit there and tell someone your uric acid needs to be below this number. I mean, good if you know, but it's not going to be particularly important. You just need to know kind of the process of it. So, we need to keep checking it over time to make sure it gets low enough. And if it's not, we can increase the dose over time. Okay, infections are the other monoarthropathies, and these are very important because you can die from this. So this is probably the only real, big alarms blaring emergency in rheum, or in MSK maybe. So people can get septic and they can die if you take too long to fix it. Ways they can get it, so you can get hematogenous spread, so you might get it from somewhere else. For example, if you've got cellulitis in the skin, if you've got endocarditis, if you've got an infection anywhere else and it's in the blood, so you've got sepsis, you can get a joint that gets it. You can also get it directly. So for example, if you get a bite or trauma, or if someone has an injection and it's not sterile, then you can introduce an infection that way. And you can also get contiguous spread, which is basically spread from something that's nearby. So for example, again, if you had a skin infection and it managed to make its way deeper and deeper and deeper until it got to the bone or the joint space. So you get gonococcal infections, that's basically Neisseria gonorrhoeae, in your younger patients. In older ones, you tend to get these non-gonococcal ones instead. And then you can pretty much just say whatever basic bacteria and it's probably a cause. You don't really get these fungal microbacterial things except in immunosuppressed patients. So risk factors, so you can have problems in the joint already. So things like rheumatoid, having implants or anywhere or any artificial joints, and literally any joint problem increases your risk of having something sit there. So it's kind of like when you have problems in the heart, and pretty much any problem with any valve will give you an increased risk of endocarditis. Same idea for joints. Outside of the joints themselves, anything that immunosuppressors use, including drugs that you might have used for something else, diabetes, CKD or CLD, so chronic kidney and liver disease, they can all increase your risk. Any recent trauma or skin breakage, and IV drug use, which increases the risk of really any bloodborne infection. So they're super unhappy with you if you try and touch it, not because you're waxing them. So massive pain. The joint infection is probably a big joint, knee, hip, shoulder. Unlikely to have, if it's a finger or something, you're very unlikely to be really having something like septic arthritis. It's probably going to be gout. Red, hot, swollen, tender, non-weight bearing, and they will have an infection. So I write this because I'm lazy, but it's fevers, chills, sweats, rigors. You should always be asking those in anyone who you have even the slightest suspicion of, even just being unwell, honestly, because you should make sure that they don't have something else wrong with them. And it's gotten worse quite quickly. So whereas with something like osteo or rheumatoid, people can kind of have this, over time, over months to years of this joint's a bit creaky, it doesn't feel like it used to, it's a bit uncomfortable, and they can't really pinpoint when it happened. Whereas for something like septic arthritis, yesterday I was fine, today I'm definitely not fine. You can ask them about risk factors for it as well, which we mentioned in the previous slide. And then on exam, they're going to look like they're absolutely hating being here. They'll have all the septic vitals. And then whichever joint it is, you still go through that look, feel, move test. So look, you're going to say all the things that you're expecting to see. So red, hot, swollen. They might be holding it extended as well, because that's supposed to open up the joint space and kind of give them as much room as possible. They're probably not going to let you examine them. And if they do, you'll find them massively tender and they'll probably stop you. And they get extremely limited range of movement on both active and passive tests. This is here because with something like a bursitis or something, active movement might be effective, but passive should be okay. And gait, they're not going to walk on it. They'll be non-weight bearing. So that's actually a really big sign. If someone's not weight bearing, you should be extremely worried about the quality of their joint. Something bad is definitely happening. So much like with other bad infections, you do want to try and get tested if you can before starting antibiotics, but you're not going to avoid giving them to like preserve your sample. You're going to treat them first if you can. And otherwise, the old joint aspirate comes back, still looking for those same things. And the things that will come out of this one is that it's going to have positive culture some of the time, probably with one of the 3 bacteria listed before, gonorrhea, Staph aureus, or streps. A super high white cell count without crystals, so we've crossed out gout then, and it's going to be really purulent in appearance as well. So on the blood, so FB, ESR, CRP should make sense. You should definitely get blood cultures. Even if you think they have gout, you might say it anyway, because you're probably going to be doing bloods on that patient, and you'd love to rule that out. And in that same vein, you can use urate to rule out gout. But as we've talked about, it's not the best test in the moment when they have an acute attack. Imaging is not super helpful. It can take a bit of time. So a lot of what you'll see early is just synovial effusion and kind of swelling in the area. And they might start seeing some more erosions later on when it's starting to erode through the bone. So this is what purulent joint fluid looks like. It looks pretty gross. And here you can see that joint space is gone, and it just looks like you can barely tell where one bone ends and the other one begins. You're not really probably going to have to figure out what septic arthritis is from the x-rays, but just know it looks awful. A couple of things you might see out of it though. So if you get these kind of grape looking things and they're all bunched up together, that's probably your Staph aureus. If they're chains and they're gram positive, so they're kind of elongated like this, you're probably more likely looking at a strep. I haven't put gram-negative diplococci because you should know that from something like meningitis or something, which I'm sure someone's mentioned already today. So managing them, definitely admit and call ortho and make it their problem, because that's their job. It's a bad thing in a joint. And so the priority is going to be giving them IV antibiotics. And that depends a little bit on what you think is going on. If you're not sure, you can just give them Fluclox and Kef. Otherwise, if it's a staph, you're thinking Fluclox because that's what works for it, as in flucloxacillin. If it's gonorrheal or streptococcal, probably ceftriaxone. The IV basically goes until you're confident they're better enough that you can swap them to an oral agent. And even then, you're going to be keeping them on that for a few weeks. having told them you're going to give them IV antibiotics, you should also do all the other nice things that people like. So doctors A, B, C to make sure they don't die in front of you. So are they oxygenated? Are they shocked? You're going to need IV access as well, obviously, to give them any fluids or any antibiotics as well, and something to make them feel better too. So you might want to give them something through this IV, not oral. So you're not going to give someone an oral dose of morphine or anything like that, because these people might need a surgical procedure, and you can't really anesthetize people if you keep feeding them stuff. Okay, osteomyelitis on the other hand, seems similar, slightly different. It's still infection, it's still bony, but it's in the bone and not the joint itself. So those same kind of mechanisms apply here. And the annoying thing about it is that bacteria can kind of get there in form of biofilm, which is basically where all the bacteria join to each other and help each other to survive, essentially. They can also start blocking off blood vessels, which can lead to necrosis and infection spreading locally. And then if you don't treat it and it keeps sitting there, eventually they'll form an abscess and a sinus, which basically is a connection between whatever deep problem you have in the skin and a sequestrum in bone, which is like an island of dead bone inside, where new bone can form around it. It's called an involucrum. So just as a picture of it, it's really fuzzy, but it does show what we need to know. So the healthy bones on either side, and you see in here, we've got this sequestrum, which is this dead bit that's essentially separated itself from the rest because the bacteria have eaten away at it. And so then around it, we're starting to form this involucrum of new bone to kind of try and contain what's been going on. And we have this sinus tract leading out to the surface from within. The bottom picture is essentially the same idea. It's still, yeah, sequestrum in the center, involucrum on the outside, and that sinus tract leading out. Okay, so different problems of different ages. So if they have any long bones affected, like that's more of a kid's thing, so you might think about that more next year. Right now, though, for you guys, vertebral, it's probably where you'd be thinking, and it's almost always Staph aureus. These other things are listed here, but not particularly likely. You're very likely to be seeing Staph aureus in there. So risk factors, other than our usual kind of joint and like any injury things for infections, any vascular problems can affect it. Because there's things like sickle cell, diabetes, and peripheral vascular disease. Because the worse the flow is, the harder it is to fight something that's down there. IV access and catheters, because obviously that's a way of providing bacteria with access to the body. Endocarditis implies you already have it, and immunosuppression means you can't fight it. Obviously, the quicker you find it and treat it, the better. You have to actually treat them for ages. So like, you're looking at a few weeks probably. Because otherwise they turn into a chronic problem, and then you get that sequestrum, and then that infection just sits there forever. So they can get a sinus tract, they can get an abscess, it can spread and give them septic arthritis and proper sepsis, and they can also just get pathological fractures, because there's no way that that dead sequestrum is going to have the same structural integrity as normal bone. So in history, some kind of infection or injury, pain in a bony site, worse at night, especially in the back and in the long bones for kids. It's not as rapid as septic arthritis. So septic arthritis is, almost a hyperacute presentation. They were fine and then they're definitely not fine. Whereas with something like osteomyelitis, it's kind of a bit slower. It's a bit more of a grumbly kind of infection. Still fevers, chills, sweats, rigors. They can still have local inflammation. You can ask them and you can examine for it. And they might have a sinus, but probably not. So on general inspection, they're going to look much better than someone who has septic arthritis, but they might still have those septic vitals. Locally, it'll look inflamed and feel inflamed, and they can probably move okay because the infection is not in a joint, so they don't rely on the bit that's infected for articulation and movement. So on investigations, so ideally you want to try and find out exactly what's causing it. And because it's not like septic arthritis, you might have time to kind of figure this stuff out, but you're probably going to end up treating them with something empirical nonetheless. So still FB, UEC, ESR, CRP, all doing the same things as we had before, and the blood cultures. If you get something in the blood culture, you don't need a bone biopsy. You might mention it anyway though. Imaging, so imaging is pretty crap, especially when it's happening. So you don't really see very much straight away. Like even here, you see that this joint space is kind of not as nice as it normally is. And there might be some kind of maybe thing of the bone in here, maybe here as well, but it's not particularly useful. The best thing to diagnose osteomyelitis early is actually MRI or a CT. wouldn't really recommend, especially if someone's just coming in, wouldn't go for an x-ray diagnostic tool, but you might do it just to see what's going on in their joint normally anyway. So this is just an example of things that you can see. So here you can see that that joint is clear, so that bone is clearly not as dense as the bone next to it on this MRI. Here, not sure what's going on there, but here's definitely a little, what's it called, involucrum forming around a sequestrum in the middle. And here's definitely an involucrum out here. You can see it's quite thick and kind of out of shape compared to where you would expect this bone to normally be. So IV antibiotics, usually they're not going to be in shock. So really you're looking at something to target Staph aureus, like Fluclox or Cefazolin, Vanc if you absolutely have to, or if you think they have MRSA. They need quite a lot of antibiotics over time. And you may or may not need to surgically remove some of the dead bits as well. So if they have an abscess, if they have septic arthritis, you are quite likely actually to need that because antibiotics don't tend to work so well in bony areas. The other things are kind of the same as on the previous one. So you need to admit them, IV access, might need oxygen fluids and so on. Call ortho, maybe ID, especially if they're prosthetics, because then ortho needs to actually have a look and figure out, can they keep it, can they not, so they need to replace it, and pain relief as needed. Okay, so others. So we got lupus. I don't know how many people watch House, but it is actually sometimes lupus. And this is not a particularly well-defined condition because it can pretty much affect any organ, most often skin and MSK though, which is why it's in the rheum part. Much more common in young women, and we don't really know why it happens. So theoretically, you need an immune criterion, a clinical one, and a total of at least 4. So I put them here somewhere. Yeah, so there's tons of these. You don't really need to memorize these because there's way too many and it's not really that helpful. At the end of the day, you're looking for the right kind of story. So, you know, this 30-year-old woman who presents with some slow onset malaise, fatigue, they have a malar rash almost every time, and they'll have something like anti-nuclear antibody, anti-dsDNA, anti-smooth muscle positive. Back for a second. So the idea is basically, normally when you undergo apoptosis, you shouldn't really be exposing your self-antigens like double-strand DNA to the body. But if you do, then your body starts making antibodies to it. And obviously, since everything has DNA, that's why you can basically get anywhere attacked. Just quickly on those criteria, so they all actually translate into real symptoms. So things like acute cutaneous malar rash. I'll just go through the ones that kind of matter here. Synovitis is that joint deformity. We've talked about Charcot's already. Serositis gives you the chest pain or abdo pain we've talked about already. They can get nephritic syndrome from it. So it is a cause of nephritic syndrome. Otherwise, these are all pretty non-specific problems. So those are probably the ones I'd take away out of that. Other things that they can have is also kind of associated with it. So you have Raynaud's phenomenon, which is where you have vasospasm peripherally, so usually in the fingertips. And so over time, that leaves them going pale and then blue because they're hypoxic, and then red when the blood rushes back. So if they know a trigger like cold, then they can try and avoid that. And also you can give them calcium channel blockers. Sjögren's syndrome is really just here as something to know the name of. Basically someone who has got itchy, dry eyes. They're not red and inflamed, they're just dry and itchy. And it's associated with lupus. Think about Sjögren's syndrome. The constitutional features, again, non-specific, but almost always present. Fatigue, fever, weight loss, myalgia. The weight gain can be from fluid retention secondary to something like a nephritic syndrome. This is an example of the malar rash, often photosensitive, and you see it spares this area here, just either side of the nose, which is the nasolabial folds. And then here we've got the discoid rash, which is basically, you can think of it as more discrete kind of lesions. And that can be either everywhere or just above the neck. Investigations, the main things here that you should know about are going to be the antibodies. So anti-nuclear, not specific, but will be there. Anti-Smith, very specific, but not present in everyone. Anti-double-strand DNA, probably the best one. They're specific and they can go up and down over time as well. The antiphospholipid ones will go over in a sec, but since that's a common association, that might be good to throw in. Otherwise, in your usual things, bedside, urinalysis looking for nephritis or nephritic syndrome. Blood's looking for basically all your basic tests, just see if anything's wrong anywhere. And then if they have pain in particular areas, then you might consider doing something like a chest x-ray or an abdominal ultrasound if they've got abdo pain. So antiphospholipid syndrome, basically people just keep on getting clots. Common places for it, cerebral arteries, lower limb veins, and also problems with pregnancies. They tend to have a ton of miscarriages quite early in their first trimester. So features of it, I do it as clot, so coagulation abnormalities, that's clotting. Levator reticularis, which is this kind of lace-like rash you can see on this side. Obstetric complications, which is the pregnancies, and thrombocytopenia, which results from them using up all those platelets to clot. Yeah, so the actual antibodies, so I know it's ABC, so lupus anticoagulant. I know it starts with an L, but it's easier for me this way. Beta-2 glycoprotein 1 and anticardiolipin. Management is basically anticoagulate them. You don't need to know tons of specifics about it. I think that's really honestly all you need to know for it. It's a subcondition of an R2. Back to SLE for a sec. So non-drug things, refer them to like probably a rheumatologist. Talk to them about triggers. So for example, if they have a photosensitive rash, maybe you should be careful about getting the light on it. Lifestyle stuff, so smoking, exercise is good for everyone. Cardiovascular risk, because it's a inflammatory problem, and treat anything else. Drugs, hydroxychloroquine is almost always what you need. You're not really going to need to run into IV steroids or immunosuppression. Hydroxychloroquine is probably the mainstay of treatment for this one, much like how methotrexate was the mainstay for rheumatoid arthritis. Yeah, PMR. So this is a condition which is actually quite distinctive. So it has a really long, scary name, but all it is really quickly getting massive pain and stiffness, especially the stiffness, without any obvious other signs of pathology like swelling. And this often goes to giant cell arteritis, particularly in the temporal arteries. It's a temporal arteritis. And 50% of people with each one can get the other condition. You don't really need to worry about how it happens because it's some idiopathic autoimmune thing. But they basically have to be over 50 years old and they're probably female. They might also have, if they've had GCA, then they're at a high risk of getting PMR. So all you need to take out of this is that the shoulder girdle is particularly affected and the hips are particularly affected. So they can have problems with basically things that require the proximal muscles to use. So rolling over in bed is a classic one in the story, but other things can be like reaching up to put the washing away, put washing on the line, or like standing up or getting out of bed, because those require those strong proximal muscles like your shoulder girdle and your quads and your gluteal muscles. They can also have these very general constitutional symptoms again, and you should also check them for GCA. So an exam, the active range of movement is going to be terrible. They might have some distal synovitis, but it's not that big a deal. And you should check if they have temporal artery tenderness too. Someone once asked me this, it's just in front of and above your tragus, which is the little bit that points backwards in your ear. So just up a bit and forward. And if you feel there, you should be able to feel a pulse there. And you can check if that's tender as well. On investigations, the main thing to take out of it is that they'll have high ESR or CRP. You can check these other things as well. So ferritin will go up or albumin will go down with inflammation, which is why it's a negative acute phase reactant. The FBE will show high white cell count and high platelet count. You can treat them pretty much just with steroids, and the fact that steroids work so well is often used to actually diagnose it. And if you think they have a temporal artery problem, you should be getting them a biopsy too. So yeah, long course steroids is what we want. It takes quite a long time to wean them down to make sure that we don't just get them to relapse in a few months. And because you're giving them long-term steroids, especially in women, you need to give them some prophylaxis for osteoporosis, things like calcium, vitamin D, maybe bisphosphonate. If they can't have steroids, you can still use methotrexate. And you should just be monitoring their ESR or CRP over time to make sure it's coming down appropriately. So GCA, we've kind of alluded to already. So here's that spot just in front of and above the tragus. Usually it's the superficial temporal artery that's affected by GCA or giant cell arteritis. And really that's probably the only one you need to know it affects. It chucks a whole bunch of granulomas in the walls, which makes it hard for stuff to come through them. Risk factors, similar to before, age over 50 and female, and smoking because it's a vascular problem. So they have a fresh headache with some things like scalp tenderness. So things you can ask them are like washing their hair or brushing it. Jaw claudication, which is when they get pain in their jaw when they're eating over time. And that's essentially, you can give it like angina for your face. They can still have all these non-specific things and PMR. And the classic thing is visual loss. And that's because they can get arteritis and obstruction in vessels that supply the head of the optic nerve, which can make it quite difficult, obviously, to see. So on exam, it might look like crap, like this, where you look, oh, that doesn't look right. I'm probably gonna get someone to biopsy that. If you feel it, it's gonna be quite thick and nodular and tender as well. You can check everywhere for it. You're probably not gonna have to examine someone for GCA, but it's a possibility that you can have it in other areas as well. Okay, investigations. So we got our FB and our inflammatory things like before, and the number one thing is temporal artery biopsy. You want that as soon as you can, but you don't have to delay treatment for it. And I can show all this granulomatous crap obstructing your vessel. So normally you'd have a nice big lumen like this. Here you've just got this tiny thing here, which explains why our oxygen supply is going to be terrible on the other side of it. Okay, so how to fix it? Still steroids. Steroids are great. They do most of the job, and then aspirin because it's kind of like a clotting type problem, and you want to try and make sure they don't have some massive cardiovascular event at the same time. Complications, think of vascular problems, stroke, aneurysm, large vessel stenosis, that's like carotids and things like that, and vision loss, as we talked about. Okay, this is probably close to the start of the weird stuff. So seronegative Spondyloarthropathies is a really long name for essentially a whole bunch of conditions that are a little bit weird and don't have the kind of antibodies we're used to finding, like rheumatoid factor. So already did psoriatic arthritis. The other ones here are enteropathic, which you can get with things like gout, with IBD, ANCSPON, reactive arthritis. And these guys will be HLA-B27 positive. So it's sensitive but not specific, which means that you can use it to say that they don't have one of these conditions. So if you get a negative result, you're pretty confident that they don't have it, because everyone who has it will have HLA-B27, but not everyone who has HLA-B27 will have the condition. So these features are kind of quite wishy-washy. So enthesitis is pain where where ligaments and tendons insert into bone. So classic one would probably be either the Achilles or plantar fasciitis, where you get classic like first step pain in the morning. Spondylitis is basically like stuffing up with your spine, especially sacroiliitis, which is between the sacrum and the pelvis on either side. And then you can get peripheral arthritis in a very non-specific whatever pattern. Big joints, oligoarticular, asymmetrical. You can get swelling of these fingers and joints as well. So enteropathic usually comes along with IBD. It can come before or after it, and usually it kind of moves around a bit. So it can be worse when they have more IBD, and then a bit better when they're in remission. You can't really prove it. You're more going to try and kind of cross out other things. And then if nothing else makes sense and they have IBD and you're finding other associated extra intestinal manifestations like these, then you're pretty confident, something like enteropathic arthritis. Usually you basically just treat the IBD. You can give them steroid injections if they've only got a few joints, but really fixing the IBD is probably the priority here. ANCSPON is the second of the two rheumatological conditions more common in males. The other one was gout before. So this mainly affects the spine, especially those SI joints. You can get it further out though, and we've talked about the enthesitis already. Over time, if you don't treat them, their spine will basically form all these extra bones and stiffen it, which is called ankylosis, which is why it's called ankylosing spondylitis. And that means that they generally tend to lose lumbar flexion. So quite gradual, and it's often in younger people as well, it's true. So it's going to be a young male, which again is quite different from all these old lady, old dude patients we've seen so far. It's very responsive to NSAIDs though, which is one way that we can figure out what it is. And some classic features are that they get pain in the buttocks on alternating sides, which can radiate down. They wake up in the second half of the night. And then on exam, most common is probably the Schober's test, which is where they have to bend over and you're drawing a line between their pieces and 10 centimeters above, 5 centimeters below, to see how much it extends. We've already mentioned these two, and fixed flexion deformity is basically, as you can see, that head is stuck flexed. So the distance between their occiput, which is the back of their head, and the wall is quite extended compared to if you went and stood with your back against the wall. So here's Schober's test. So A is at the level of the pieces, 5 centimeters down, 10 centimeters up, and you're looking for it to lengthen by at least 5. If they can't do it, then we're thinking something like sacroiliitis or ANCSPON, yeah. Yeah, so bloods, FB, HLA-B27, sorry, that should be the other way around, to exclude, not to prove it. ESR-CIP is not that helpful. The X-rays are pretty good. So sacroiliitis and bamboo spine. So we'll have a look at what those look like in a second. You can use MRI, but it's not very commonly done. So bamboo spine, as you can see, this is our normal spine. You have this nice separation between the vertebrae with the articular joints in here. But in this one, we've got all these syndesmophytes, which are basically growths of bone along the peripheries of all the vertebrae, joining it together so it looks like one big long stick. If you think about that, it makes sense why you can't really bend that very well. Then sacroiliitis, so here you've got our normal spine, and you see all this nice space in here, whereas over here, all this fuzzy white crap kind of at the edge of it. And that's what's going to make you think of more along your sacroiliitis type line. What is the question? OACD. Sorry if I wrote OACD wrong. It should be AOCD, as anemia of chronic disease before. Okay, so management, still very non-specific things for the most part early on. Educate, don't drink, don't smoke, do some exercise. NSAIDs can be very helpful for these patients as like baseline pain relief. And DMARDs are particularly useful for, so specifically TNF alpha inhibitors are especially useful for this. You can use other ones like sulfasalazine, methotrexate, but the best thing for these guys is going to be something like infliximab or etanercept. These options down here, like steroids and stuff, less so. Yeah, reactive, much more relaxed. Basically, you have a single joint or a couple of joints which are inflamed and painful after getting either a genitourinary or a GI infection. It's basically a sterile joint aspirate. So if you go, oh, this person's got a freshly swollen joint, I'll quickly aspirate that and check what's in it. You'll find there's nothing in there. It's just normal. They still have the same kind of features of any arthritis, pain, swelling, stiffness, and they can have all these extra articular things again, dry eyes, Achilles tendonitis, that back stiffness. Pretty much it goes away on its own. They don't really tend to get chronic disease. Usually just give them some NSAIDs for a bit and they'll probably be okay. Okay, we're gonna fly through the rest of it because we've only got, oh no, we got what, 15 minutes? Yeah. We're now on to the less big deal things. So fractures, you should know a bit about because it's on there. So I'm just going to go through some pretty basic things about describing fractures, what you need to do for these people, but you don't need to know tons. So good to be able to name which part is broken. In kids, you can worry about the physis, but for adults, it's basically diaphysis or metaphysis. So pretty much you can just say one of them. You can also just say shaft. You should be specific with things like the femoral head, which we'll get to in a sec, but usually it's probably going to be a shaft fracture. So things that you can talk about, you don't need to say all of these or remember all of these, but just keep these broad headings in mind. So you want to talk about what kind of line the fracture has. So is it oblique, or it's kind of angled? Is it directly across and transverse? You should know all of these, except maybe comminuted. Comminuted means that the bones essentially have like splintered or fragmented. So you have little bits of it around, usually broken into multiple pieces, as opposed to when your simple kind of fracture like that. Fracture location, so basically just call it in terms of which bone it is and also where on the bone. Positioning is about how it's changed compared to normal. So has one of them been displaced medially? Are they angled, which we use for AP, as opposed to displaced, which is more for left and right or medial or natural? Rotation can be hard to spot on X-ray. Distracted means they've been pulled apart, impacted and shoved together, and avulsions where something's been torn off by a ligament or something like that. And lastly, tissue quality. So in terms of, does the bone look okay? Is the soft tissue swollen or looking gross? And is it an open fracture? So this is just some pictures of what each of those might look like. So transverse, across, this is displaced now. Compound fracture, so there's probably more pieces of it somewhere. And also you can see it's quite jagged. Oblique, comminuted, now we've got all these little pieces around, and green stick, where we fractured one side through the periosteum, but we haven't made it to the other side. So Salter-Harris is a thing, and we were told about it, so maybe it's worth your while. It's really just a way of describing what kind of fractures you get. I don't think you really know the difference between managing them, but it's probably a good thing to keep in mind. So you essentially use the letters of Salter to tell you what it's gone through. Straight across is through the physis, above, lower, through everything means through metaphysis, physis, and epiphysis, and ram is where it's broken, and then they shove the joints, shove the two fragments together. So here you can look at this, probably a spiral fracture here. It looks quite spiral. You've got a comminuted fracture here. And here it's quite difficult to tell, maybe an oblique fracture through there as well. So none of these look like much fun though. You'll notice that so this is tibial, and this is femoral. Okay, history and exam, very simple things: where, when, how it happened, any other injuries, and important things that you need to get out of anyone you're assessing for a fracture is if they're neurovascularly intact. So the neuro part, you're asking about maybe if they can move peripheral parts, and then if they have any areas of pins and needles, any areas of numbness. For vessel issues, you're looking for things like, are they pale, are they cold? And then that's especially something you're going to check on the exam. Speaking of the exam, so firstly, just look at them generally. Do they look obviously unwell? They probably will. Or they might be actually managing okay. Then look at the injury itself, and you want to see if it's open or closed. So can you see something sticking out? It's obviously deformed. Does it look like it's quite, relatively intact and kind of where it's supposed to be? Are they bruised locally or pale? Pale is important because we're thinking about that vascular compromise again. And palpation, you're basically checking if they're NVI, just neurovascularly intact. So sensation, pulses, movements as able, but you're not going to be getting these people to stand up or walk around or anything like that. Management. So once again, we're going to call ortho to figure it out. Some kind of pain management, give them whatever feels appropriate for that person. Probably an opioid. Try not to give people oral things because, again, they might need surgical management. You immobilize them for now and get an image. So just to recap, edit them, pain, immobilization, and imaging. The immobilization can actually help with the pain as well. And specifically for the scaphoid, because that's vulnerable to occult fractures where you can't see it on an X-ray, you might consider doing an MRI or CT first instead. Then once you've kind of got everything ready for ortho to come do it, they can fix the problems. So they might not reduce it. So for example, it's not displaced. They might just cast it. They might do a closed reduction. So they don't make any cuts or anything. They just kind of push it back together where they think it should be, get some X-rays and make sure it's right. This is under local or generalized anesthetic. Or they can do open reduction and internal fixation, or ORIF. And then if you're not sure, because all the different fractures have like a whole bunch of different guidelines about how often you should come, just say 1 week, 3 weeks, and 6 weeks, because most people will follow that timeline. Femoral fractures are a specific thing that we'll mention because they can be, I guess they're a type of fracture you should probably know a bit about because old people get them, and lots of old people get to hospital. So you can name them according to, firstly, are they capsular or extracapsular, as in joint capsule, which is basically up to here, so up to the end of the neck of the femur. So we've got capital fractures at the top, subcapital, which is just at the bottom of the head of the femur, but isn't on this neck segment. No one's going to take your head off if you say subcapital instead of transcervical. But if you can obviously see it's on the neck, then just say transcervical. Intertrochanteric is between your greater and your lesser trochanters, and subtrochanteric is everything lower than that pretty much. So this one, we've probably got a, what we say, maybe subcapital fracture on the left here. So you can see that on this side, it's quite, nice and regular. And then here we've got this little bit here that's not quite right. You can see there's a break in the cortex along here as well. This one, more clear cut, probably a transcervical fracture, this time on the right. And so you can see, so there's something called, do I have it here? I will come back to it. But yeah, you can see this side doesn't look as nice across the neck as here. You can see this bit sticking out in the back, so clearly something's not quite right here, because it's quite nice on this side. And this is probably an intertrochanteric fracture, maybe comminuted, because we have this chunk lying around over here. Yeah, so here's the great trochanter. Lesser would probably have been down here where this was before. So Shenton's line is a little thing you can use to mark that. And so it goes along the superior pubic ramus, which is here, down through the medial side and the bottom side of the neck of the femur, which is this whole chunk here. So ideally, it should look reasonably nice. It doesn't have to be perfect, but it needs to be pretty good. If it's not, then you think they might have had a NOF or a neck of femur fracture. So from here, we're on to the weirdest of things. So they're basically just conditions that you should have heard of, maybe know a couple of buzzwords for, but you definitely shouldn't stay awake at night thinking about things like Wegener's vasculitis. So it's also known as GPA or granulomatosis with polyangiitis. They'll probably give you both names, but good to know both in case you run into it. And you can get a million symptoms with it. So the ones that you want to take out of are sinusitis plus hemoptysis plus hematuria plus this, that probably should be more petechial type rash here. And this is an ANCA-associated vasculitis, and you immunosuppress them. So this can sound a little bit like Goodpasture syndrome or anti-GBM disease. So they'll have the hematuria and they'll have the hemoptysis, but they won't have sinus pain or a macular rash. Choked Strauss, different one, so it's eosinophilic this time, so it's more allergic. You don't need to know lots about this either. Essentially just palpable purpura petechiae, and you should probably give them steroids. And it looks kind of like this, so very dark petechial, maybe even, sorry, bigger than that, purpuric or palpable type rash. And the myositis is, I'm not even going to bother with these because they're not, you should just know heliotrope and Gottron's means dermatomyositis, and maybe anti-Jo1 for polymyositis. But this is very much, you know, this is bottom of the barrel stuff. So these are Gottron's papules, just in case you get a picture of them. It's basically these like red, thick, gross looking things that you get kind of on the finger joints. So you can see they're on the metacarpophalangeal joints, the PIPs and the DIPs. You can just see out here. And that's the heliotrope rash. It's basically just on the eyelids. Scleroderma, literally just have heard of it. I mean, it's just not your problem. So the main thing to take out of this is probably the crest thing, because that's usually how you hear about it. So calcinosis cutis and sclerodactyly kind of go together. So that's like calcinosis in the skin. Sclerodactyly is where you have tight skin on the fingers, which you can barely even see, but I guess you can't see many wrinkles on these hands. And that means that they can't move them properly. Raynaud's we've talked about, esophageal dysmotility, so they can't swallow. And telangiectasia is dilated blood vessels. Okay, so I have a couple of questions at the end just to finish this off. So feel free to just you can either just message me privately if you don't want anyone to know, or you can just chuck in the chat, or you can unmute and tell me which you think it is. So a 43-year-old lady presents to the GP with 3 months of fatigue, malaise, which she can't pinpoint the cause of. She's had some associated shortness of breath and stiffness in her fingers, which takes an hour to be relieved with activity, but returns with rest. On exam, she had non-correctable deformities and warm effusions of the MCPs on both hands. So what's she most likely to have? Oh, look at everyone flying in with these. So for those of us going with B, that is correct. So for this lady, so let's cross out all the other ones. So osteoarthritis, you're not going to have all this generalized fatigue stuff. She's still young as well to be any mechanical problem, though they can. Lupus, so this is non-correctable disease. So correctable disease will push us more towards lupus. Chronic tophaceous gout, she doesn't have any tophi that we know of. She doesn't have massively painful joints anywhere. And psoriatic arthritis, very unlikely in this situation. There's no skin problems, there's no nail signs. The next one, so 52-year-old man comes to ED with a hot swollen knee, which has developed rapidly in the last day. He describes 8 out of 10 pain and refuses to be examined. He's had an urgent joint aspirate revealing negatively birefringent needle-shaped crystals and has no other comorbidities. So which combination of agents should be used for acute pain relief and long-term management of his condition? Yeah, okay, very good. So it is, oops, I didn't pronounce the slide in here. I'll chuck that in on the post slides, but yeah, it is C, like everyone said. So going through this, no one needs antibiotics here. This is gout, as you've all figured out. So they're not going to need pred. And acutely, we should be giving NSAIDs for pain relief, and long-term allopurinol, 100% your first-line agent for urate lowering therapy. So this guy has his acute treatment and he gets his long-term therapy in conjunction with his appropriate lifestyle changes. He's had no side effects and has been enjoying his new healthier lifestyle. 8 months later, he comes back for a relapse. Which of the following is the most appropriate next step? Should we stop his therapy, increase the dose, keep it the same, change drugs, add a second drug? Okay, right, so, here we go. This one is C. So this is straight off ETG. They bothered putting a red box in there, so I thought I'd take it as well. Don't touch anyone's long-term therapy while they're having an acute episode. Afterwards, you know, if he's clearly not getting treated to target if he's having a relapse. So you might change his long-term agent. I think I would probably long-term give him a second one because he's not having any problems with this one. So you'd really be adding something on to kind of increase the urate lowering therapy effect. But you won't do that until we finish treating this. So the most appropriate next step is to keep it exactly where it is. Oh, well, I don't know why this is here. Oh yeah, which of these, in addition to clinical findings, is the best test to diagnose rheumatoid? Yep. Cool. Yep, so it is indeed anti-CCP. It is the best test. ESR-CRP will be up, but won't be that helpful. Rheumatoid may or may not be up and can also be elevated by other things. X-rays, yeah, they can show some changes, but you really want the anti-CCP to kind of nail that shot. Okay, Mrs. HT is a 70-year-old lady who comes to a GP with sudden onset stiffness, stopping her from getting out of bed and putting the washing up. So she's leaving these tasks to her husband instead. She describes feeling a bit warm recently and she's been well until just now. So how should she be treated? Yeah, so this lady has PMR, so she's got sudden onset stiffness. The washing up is that proximal problem superiorly, or yes, like in her upper limbs, and problems getting out of bed is that lower limb proximal myopathy. So she should get a whole bunch of steroids to basically keep her from, well, basically to treat her condition. So she'll feel better pretty much in a few days and then maintain those over time. Oh, someone has noticed they're all C. Okay, and then which of these are false? So you got morning stiffness for RA, but not OA. Normal X-ray excluding osteoarthritis. Drug choice for rheumatoid is methotrexate. PMR predominantly affects the proximal muscles, and septic arthritis can be rapidly fatal if untreated. I put the wrong, oh yeah, ignore E because I put the wrong option there, but both A and B, this was a which of the following are false. Morning stiffness you should be seeing with both. Sorry about that last one. Morning stiffness you definitely will see in both. Remember, it's longer for rheumatoid because they're for a really long time. And a normal X-ray does not exclude OA. As we've said before, if they have symptoms but no X-ray signs, you're still going to diagnose them with OA. So that takes us to the end. Thank you guys for coming and listening. I hope that was helpful. If some of it doesn't make sense, feel free to email me. Hopefully I'll be able to answer it, and enjoy the rest of your day. I suppose it's been a long day so far. Yeah, and good luck with exams.
Thank you so much, Max. That was really wonderful and really appreciate you taking the time out for that. Best luck for your exams as well.
Thanks.
And for the last lecture of the day, we have a presentation on endocrinology. We might just break for a few minutes and then start at about 3:55, if that's fine.